My name is Carmen Finn, and I am the Senior Director of Treatment Services at Wayside Recovery Center. Today we are discussing behavioral emergencies, and so I'm actually going to be going through our policy and procedure manual, which can be found at each of the residential sites. And so afterwards, after you review this training, you can go back to the operating policy and procedure manual and review or look at other topics if you're interested. So in the policy for behavioral emergency, it says any client who is exhibiting behavioral problems will be provided with appropriate levels of care and/or removal from the escalating situation for their protection and the protection of other clients and staff. Forced seclusion, physical restraint, and chemical restraint are not used at Wayside. Any client who is experiencing a psychotic episode will immediately receive the necessary mental health and/or psychiatric treatment warranted by the condition. So some of the behavioral problems that you might experience could be mental health related, and we've seen everything from clients having manic episodes, so perhaps they're experiencing some increased aggression, talking really rapidly, being impulsive. They can also be experiencing some form of aggression tendencies, which can be related to several different mental health concerns and symptoms. And so we want to look through that lens of how do we get the client appropriate care in a behavioral emergency. If at any time you feel like you're threatened, the client themselves is threatened, or some other person is threatened, either their physical well-being or possible loss of life, you do want to call 911 immediately. And so follow what the 911 operator says and focus on getting other clients to safety or keeping the individual who is threatening themselves safe in the moment while you wait for emergency care to arrive. And so that would be appropriate level of care in an actual emergency. But escalating situations, we do also want to take protective measures. We do not, as the policy states, use forced seclusion, physical restraint, and chemical restraint. So basically what that means is we don't lock clients in rooms in order to keep them safe or other people safe. We don't put our hands on a client and physically restrain them, hold them in any way, shape, or form. And we don't use any kind of chemical restraints or any kind of medication or anything that could restrain them in that way. If 911 comes, if the paramedics come, they of course can do what they need to do in that situation to try to keep everyone safe, or the police. Any client who's experiencing a psychotic episode will immediately receive the necessary mental health and/or psychiatric treatment warranted by the condition. So psychotic episodes include clients who are experiencing breaks with reality, hallucinations, that sort of thing. And if you're unsure if it's a psychotic episode, of course you can always call the on-call clinical counselor or speak with your supervisor. If you feel like it's reached the level of emergency and you are unsure, you can again call 911 and talk to the paramedics and the 911 operator about what you're observing or seeing if you have concerns that it's reached the level of emergency of client being a safety concern to themselves or others in that situation. The staff on duty are responsible in trying to aid and de-escalate the situation. So in the event that of the behavioral emergency that the client is attempting to hurt someone else, you are in charge of making sure you've called 911. Often I encourage people to carry the cell phone around with them, especially if they're direct care staff, and making sure that you are calling out for help with your other colleagues and trying to get other clients removed from the situation in their rooms, asking them to go to their rooms or leave the situation. That way you can kind of de-escalate. There aren't people hanging on watching whatever is happening with the client who's having the behavioral concern. Emergency procedures must not be used to enforce facility rules or for the convenience of staff. Emergency procedures must not be part of any client's treatment plan or used at any time for any reason except in response to specific current behaviors that threaten the safety of the client or others. So the first step in a behavioral emergency, if the client is displaying behaviors that threaten her own physical well-being or that of any other person, you do want to ask them to stop and then leave the area and go to a safe room area or to leave the building. So if the person is threatening themselves and you ask them to go to a safe area, you do want to make sure that staff are present and observing the client at all times, because we don't want to ask them to leave and be by their own and perhaps they go and they hurt themselves. So in the event the client is having some sort of suicidal ideation or self-harming ideation, you definitely want to make sure that another staff person is present when you're removing them from a situation, and so that they can have some sort of observation, and then we can assess the situation further. So if you're a direct care staff, like a recovery advocate, you might then choose to have one of your colleagues sit with the client who is threatening to self-harm, and then go get a clinical staff person to do a more thorough suicide or self-harm assessment. And then you can follow the direction of the clinical counselor at that point in terms of what to do next. In terms of asking them to leave the building, those are situations that perhaps the person is threatening to harm others. And if in that case, if it's that serious and you really need them to leave the area, some of the techniques we've done in the past is, why don't you go out to the back and just get some fresh air, and then if they're, of course, not able to de-escalate and they're continuing to threaten others, and you're concerned about the fact that they are not de-escalating, then you definitely want to get the emergency paramedics or police involved. So staff on duty will meet with the individual to aid in de-escalating the problem and to evaluate the level of removal necessary. So again, that's that assessment piece, and so we do want to figure out what level of care that client needs at that time. And all other clients will be asked to go to another part of the building. So again, asking other clients to leave the situation, so the client who is having the behavioral health emergency is able to have some privacy while they're de-escalated, and then the other clients are safe and removed from the situation. And again, it's reiterated, and I know I've mentioned this several times, and I do want to be really clear. It is in our policy that if there is a threat of violence to a client, another client, or staff may contact the police immediately. If the clients actually do get into a physical fight with each other, please call the police and let them know that there has been actual physical harm, and so the police know that when they get on site, they are going to need to talk with the clients and make sure that they are both safe, and that the paramedics might be needed at that point. I'll also say, while I'm talking about it, that if clients are engaged in a physical altercation with each other, remember that our policy is that we do not do restraints, and so do not get in there and restrain one or both of the clients. There's a lot of reasons for this. One, it is actually in our policy that we don't restrain the clients, and we don't want to accidentally hurt them while we're actually trying to help. But another reason for this is we don't want to see you get hurt. And so if clients are punching each other, holding each other, wrestling, and you would try to get in there and then you would be punched or hurt, and then at that point you're unable to do the rest of the policy, which is to call the emergency procedures like the police, paramedics, and get immediate help. And you would also be unable at that point to assist the other clients into getting to a safe area because you would be incapacitated when you were hurt. So we don't want to accidentally hurt the clients, and we don't want you to get hurt. And so your main priority if clients are actually having a physical altercation is, again, to ask them to stop, to leave the situation. And of course, if they're not doing that, calling 911 immediately, getting the emergency people to the scene, and then you are focused on getting other clients out of the area and getting assistance from colleagues or other staff as well. After the emergency behavioral health situation, you've either contacted the emergency procedures or gotten clinical people involved to help, you do want to make sure that you contact the on-call counselor and review the incident with the clinical director or manager at that time. If one of the pieces of the assessment with the individual is that psychiatric services appear to be needed, then some of the options that you need to consider is to contact the client's psychiatrist for hospitalization evaluation, ask the client's counselor or the clinical director to make that call. You can also call the Community Outreach for Psychiatric Emergencies, which is COPE, C-O-P-E, and the number is listed in our operating policy and procedure. It's in Section 11, and you can also easily find that online as well as other manuals that we have in the RA office. COPE can arrange an emergency evaluation for inpatient psychiatric services. The COPE team is available 24 hours a day, 7 days a week. So they're a team that comes on site and can assess the client's mental health and figure out if a hold needs to be placed and the client needs to be hospitalized for their mental health. You can also, if necessary, arrange to have the client seen at Hennepin County Acute Psychiatric Services or APS. And again, that number is listed in our policy and procedure manual and is also available in several of our manuals in the RA office. APS is located at HCMC near the emergency room, and you do want to call APS prior to sending a client to that facility. Complete a clinic visit form and forward it with the client when she's transported to the center. And of course, while we're doing these things, we're also making sure appropriate releases of information are signed. If the client is referred to the acute psychiatric services and then returned to Wayside, a written note of the referral and the recommendations received from APS staff are documented in the client's chart. So basically just making sure that whatever APS said needs to happen for referral or any additional recommendations is documented, and we're following through with those recommendations that APS sent back. If it's determined that the client is to be seen or transferred to another facility, the staff member on duty is responsible to ensure that arrangements are made for appropriate safe transportation to that facility, either a family member, agency van, police, ambulance, that sort of thing. So appropriate level of transportation. If a client is threatening self-harm or harm to others, it may be much more appropriate for them to go to a transferred facility via ambulance so that they have someone who's watching them and can provide additional support during transport to make sure that the client does not harm themselves. So those are things to consider. If it's not that urgent or that level of an emergency, then it may be possible for the client's family member to potentially transfer them so they still have support as they go to a different facility. Any use of these procedures needs to be documented in the client's individual file and in an incident/accident form. This documentation includes the description of the behavior you observed, the time it happened, the date it happened, the staff that were present during the behavioral emergency, the method and procedures used, and the outcome of procedures, referrals, or transfers. And we make sure that all staff receive the same training every 2 years. If you have any questions or concerns about any of these policies, behavioral emergencies, please speak with your supervisor and get additional training on these things. Additionally, some things to think about is what is within your scope of practice to assess, what type of interventions you can use. Another good thing to take note of in terms of behavioral health emergencies is that we do also make sure that there is a staff who is CPR and first aid trained on site at all times, and those are generally our direct care staff or recovery advocates. And so that's important to know too, that we also have someone who's first aid and CPR trained on site. Make sure you do talk to your supervisor if you have additional questions or concerns, and review these policies or procedures whenever you have additional questions. The last thing I want to talk about is mental health first aid. So we discussed briefly about attempting to de-escalate the client. First and foremost, it's really important that you yourself stay calm. And so if you notice that you are experiencing your own blood pressure to go up, your heart rate going up, and you're starting to experience some anxiety in a situation of a behavioral health emergency, take some really deep breaths and just focus on trying to calm yourself. So I like to say the first step in any mental health first aid is to check in with yourself and breathe. And then we want to approach the situation and assess and assist with the crisis. And listen non-judgmentally to what's happening. So if the client is angry or upset, listening in a non-judgmental way, giving support and information on options the clients can do to help themselves de-escalate. Some clients have a de-escalation plan if they're known to have behavioral health emergencies or they tend to escalate, and it might be helpful for you to find their de-escalation plan and provide that information to the client in the moment. And you can encourage appropriate professional help. The client, there's lots of availability for them to talk with other staff, other clinical staff, case managers, counselors, other recovery advocates. They also can call outside of Wayside. They can utilize COPE. We can always offer them to have COPE come on site. So if they're upset or angry with Wayside, sometimes it's helpful to have another agency like COPE come in and they can talk with them. There's walk-in counseling services that they can utilize and other resources available in manuals throughout the organization. If you have any additional questions about mental health first aid or ways to de-escalate or crisis intervention techniques, again, we will provide additional training to you and you can talk with your supervisor. I'm available if you have any additional questions about our policy and procedure around behavioral health emergencies. Thanks for watching.